Dixon is going to be presenting, talking about traumatic brain injuries through WVU. So I'm excited to hear what he has to say. Thank you for agreeing to do this, Jeremy. And whenever you're ready, I'll pass it to you.
All right, sounds good. Thanks again for having me. A couple of you were on the last call a couple of days ago I presented, so it'll be same information. We got a lot of different faces on, so that's good. So let me have a presentation. I'm not going to go over too much detail, everything, but I do want to, I think, go over a lot of this stuff and kind of give you the reason why, obviously while I'm here. But yeah, I'm Jeremy. I'm the outreach coordinator for the Traumatic Brain Injury Program. We are one of the many programs under the Center for Excellence and Disabilities. So yeah, and if you want more information about the CED and the different services, obviously you can reach out and I can provide you that information. This is the brain here, but I'm not going to go over too much detail, but I do want to focus more on the frontal lobe because that's going to be where a majority of the brain injuries do occur. And it's a large lobe of the brain and obviously the most common, like I mentioned, but it is probably due to the sheer location and size. But it is going to be the one that you're going to probably see a lot of those symptoms that you would be able to see what they actually control kind of come out, especially in the reentry and even substance use demographic. Your personality, that's basically your personality hub and where all your executive functioning skills take place. Your organization, your attention, your memory, problem solving, decision making, emotional behaviors, control, all of that's going to be kind of in that frontal lobe. So there is a definition. This is West Virginia's kind of definition and legislative definition, but it's a disruption. A traumatic brain injury is a disruption of normal brain function, and it can be caused on many things: a bump, blow, or jolt to the head, or a penetrating head injury, which would be like a gunshot wound. And in West Virginia specifically, they classify a traumatic brain injury also due to anoxic brain injury due to near drowning. So essentially that would count, but like a drug overdose, for example, would not count. So that's just more a legislative definition that we have to kind of go by through our grant. Many different, categorically speaking, there's different classifications with these brain injuries. Mild, moderate, and severe. Everyone's probably heard of a concussion. And that is a mild traumatic brain injury. It's classified as that. In moderate to severe, you'll get to more of that loss of consciousness and some more symptoms, long-term symptoms usually after that. But don't take the mild concussions, mild brain injuries, so light, because if there are multiple of those, then it can obviously cause some long-term damage as well. Some of the symptoms here, I do want to go over a few of those. You're going to probably see with some of the folks that you tend to is more on that right-hand side with behavioral and emotional impulsivity, elevated depression and anxiety levels, personality changes, mood swings, and even some aggression can be, some of those symptoms after a brain injury. But that's kind of the end result, but I think it's always starts kind of in the middle where the physical and motor symptoms. So headache's going to be your biggest excuse me, your biggest complaint after a brain injury. With some sleep disturbances, if you have those two on one, just if you just have those two symptoms, for example, it's going to affect your cognition on the left-hand side. And you're going to have difficulty with problem solving, flexible thinking, and then obviously it's going to kind of relay right into that and kind of go right into that behavioral and emotional issues. Many different causes. In the state of West Virginia, from our clients that we see, majority of that, or that 33% are from motor vehicle accidents in the state. You can see falls is 27% here in West Virginia, but if you look at national numbers, falls is actually number one across the country. I'll get a little bit more specific numbers here in a little bit about causes. I do want to go over risk factors. I think it's really interesting how those risk factors come across. Males are more likely to have TBI. Children under 4 in the age group 15 to 24. If you kind of look at independents, for example, like age group 15 to 24, they're probably going to have more motor vehicle accidents, ATV accidents, fights. sports injuries, all that's going to be kind of in that category. And then you'll see adults over 60, that's going to kind of be more that falls demographic. And then at bottom right-hand corner, that history of a brain injury, it's always kind of eye-opening, I think. But 3 times more likely to have a second brain injury and 8 times more likely to have a third brain injury after you've already had 2. So if you had one, you're more, the chances are you're going to have a higher likelihood of having a second one. Okay, so I'm going to go into some substance use and brain injury. There often results in headaches and orthopedic injuries for which they are prescribed opioids. Between 70 and 80% of patients with TBIs are discharged from the hospital with a prescription for an opioid. Pretty elevated and high number, right? Especially when you think about all those symptoms I just talked about, memory symptoms, impulse control symptoms. So if they get a little bit of relief, from that brain injury, some of those symptoms just from that opioid, that can probably cause them, obviously just kind of start overusing that particular substance. It's frequent, the impaired judgment in impulse control, like we talked about, which can lead to overuse of pain medication. And one of those saddest ones here at the bottom bullet, people with TBI are 11 times more likely to die of an overdose than those in the non-brain injured population. So I always want to highlight that because I think it's just such a significant number when you look at some of these statistics. This study is really interesting. It's a birth cohort, so they followed these individuals from birth till they were 25 years old, and they kind of came up with some really interesting numbers. So if you were hospitalized, sorry, my email just dinged. If you were hospitalized with your first traumatic brain injury before the age of 6, and if you remember those at-risk population or at-risk ages, below the age of 4 was one of those. So if you're hospitalized with that person before the age of 6, you're 3 times more likely to have either a diagnosis of either alcohol or drug dependence by your mid-20s. Say age 25, mainly because that's when the brain normally stops developing. And then a very similar number again between 16 and 21, again, was one of those elevated risk factor ages. Yeah, you're still, again, 3 times more likely to be diagnosed with drug dependence as well. So I still think those are so interesting numbers when we look at that. And then the bottom bullet, they're highly likelihood of TBI, or highly likelihood of arrest. So TBI at around 60% of the incarcerated population, and about half of those resulted in loss of consciousness. Like I mentioned, those are moderate to severe brain injuries when they lose consciousness, right? So that means their symptoms are probably going to be a little worse for a longer period of time. We talked about some behavioral health symptoms and depression and anxiety, how that actually affects your brain and how it affects after a traumatic brain injury. This is a study clear back in 2003, which I know it's an older study, but mental health really wasn't on the map as far as much it is now, and those mood disorders. And even at that time, those numbers were so kind of elevated even then. So even after that second, excuse me, after that second brain injury, from the blue, 0 brain injury, 30% of those individuals had depression, but after that second brain injury, almost 60% had elevated depression levels. So then if you just look at that gray line all the way down, elevated anxiety levels of 53%, violent thoughts skyrocketed as well, 54%, and even the suicidal attempts and ideations pretty much doubled as well after that second brain injury. You can kind of, I know you guys in the REACH initiative, I'll put this number out there before, but on average, we make about 35,000 decisions a day. And then in the incarcerated population, I believe it's about 100. I think the REACH initiative always kind of, in some of these reentry calls, talked about that, which is kind of incredible to think. So if you have somebody, obviously in the reentry population, used to only making 100 decisions a day, especially if they've had a brain injury and there's no, if that cognition is affected, their executive function, they have no motivation, there's a ton of different things. And then you release them out into, from a reentry standpoint, they're kind of going back into, daily living, and how are they supposed to manage all that stuff, especially adding that brain injury piece on top of it. So I'll skip down to that bottom bullet, but over 7 million people are under supervision in the criminal justice system. And then, if you put that 60% number roughly, there's almost 4 million people, living with a brain injury within the justice system. It can also lead to homelessness, especially you guys were talking about some housing situations earlier. Brain injury are associated with lower employment rates. That chronic pain may cause someone to self-medicate, which we kind of talked about that a little bit at the beginning. Cognitive issues may make it difficult for someone to manage money or remember appointments. And then they have challenges with emotional regulation. Obviously, they can lead to conflicts and that aggressive behavior as well. This one's always pretty eye-opening as well. About 75% of those acquired in the homeless population acquired a brain injury. Sorry, my dog is like whining to go outside right now. Acquired the brain injury before they became unhoused, and about a quarter of those had the brain injury before they were 15 years old. So again, at-risk populations that younger age, and how important it is to manage those whenever they're at a younger age, just so we, will help reduce that drug and alcohol dependence, especially, as they get older. All right, so screening. That's kind of what we can do to help, right? We can help screen, accommodate, and some support those individuals. So I'm going to talk about some of those screenings like there's a lot of tools out there, but we use the Ohio State TBI ID method. It's an interview designed to elicit a lifetime history of traumatic brain injury. And I like these questions because it does trigger your memory. And I'm sure some of you probably say you've never had a brain injury, but after you've read some of these questions, you're probably going to look back and think about it a little bit more after that. That's the card that we developed. Again, we just utilize the first 5 questions of that screening tool, but which we got permission from Dr. Corrigan. He's from Ohio State, so we got permission actually to shorten it just for this purpose, is in order to get buy-in from partners, and in order for them to help the clients that they serve. So this is the 5 questions. So have you ever been hospitalized or treated in an emergency room following an injury to the head or neck? Think about any childhood injuries you remember or were told about. Have you been injured in a car accident or from crashing some other moving vehicle like a bicycle, motorcycle, or ATV? Have you injured your head or neck in a fall or from being hit by something? And then it has some examples in there, just so, again, trigger memory. Falling from a bike or a horse, rollerblading, falling on ice, being hit by a rock. Have you been injured playing sports or on the playground? So again, triggering memories, right? Have you ever experienced your head or neck in a fight or from being hit by someone or being shaken violently? Have you ever been shot in the head? And then the last one's more of a military, the military population, been nearby when a blast or an explosion occurred. Have you served in the military? Think about any combat or training related incidents. So I know it's a lot, but it's very quick, but it's a lot. It's very dense in the material that's in those 5 questions. So we've been able to implement this quick screener into Recovery Point in the southern part of the state and a couple other locations. But Recovery Point's been doing it the longest for us. February of 2023, they started implementing it into their intake form for everybody that comes through the door, goes through their intake process. They kind of make it part of their ASAM, thing. So I kind of want to reveal those numbers because I think they're very eye-opening and kind of crazy high. So if you look in the February 23 number, they screened a total of 25 individuals, and 19 of those answered yes to one of those 5 questions. And they quickly implemented it to the other facilities, all of the other 4 facilities total in March of 23. So you can just kind of see the total number. They've screened over 600 individuals, and 361 were positive for a positive screen, essentially, for that brain injury. Pretty big numbers, and they've been a great partner with us. We've actually have an IRB with them to do some research, and we actually just developed a poster a few months ago with them about and kind of some of the data we've been collecting. They give us all their intake information, and we're able to break it down into some different categories. But the research we've done, this is kind of the, this is the poster we came up with. I'm not going to read it, but I did want to say this is over 100 and this particular study is for 183 total so far that we've been able to do, not the total 361, and obviously the newer ones that we've clients that we've gotten. So if you look on the left-hand side, figure 1, the biggest cause motor vehicle accidents is kind of number 1 in West Virginia, which holds true. But that second one piece comes pretty high is violence. Violence is really not one of the top ones in the state and or the country, but in this particular demographic, obviously violence is a lot. It's very high. And falls looks like it's like number 4. Okay, and then falls is number 1 across the country. So it's really interesting to look at that. If they've ever used substances on the side, on the left-hand side, you can look at how many of those use the different substances. And I know I kind of referenced the prescription opioids at the beginning was between 70-80% at discharge. If you look right at this number, 75% is it's right smack dab in the middle of that statistic, which is kind of verifies that one. On the right-hand side, I know we talk about mental health a lot and different triggers, you know, for someone with substance use, difficulty dealing with feelings is the first one, mental health, 4th one, always very, very big in that. And negative implications, legal implications, obviously, mental health again, sneaks in there at number 4. You can see the other ones. I'm not going to read all of them, but you can kind of see those implications of that usage. But I thought that's really interesting. We're always looking for partners to do this type of stuff with. So if you're interested, and obviously please reach out. So one of the things we've been able to develop, you're like, okay, we screen, great. What are we supposed to do, right? So this is a symptom strategy card that we've developed. We got a couple partners and resource partners we utilized in this, but it's essentially like a slider card. So there's in the paper version, right below it, the directions in the paper version that we have in hand, there's a little text box. So the part on the right, like if you look at the top, lose track of time, misplacing items, that type of stuff there, that's a memory symptom. You know, if you have a symptom of a memory, it's like, okay, I forgot what I did yesterday, I forget my meetings, all that stuff. Right. But if you flip the card over, there'll be a text box on the back, and then in the top right hand corner, you're going to see ways to accommodate for that specific symptom. So use a calendar, try setting reminders for yourself, schedule appointments on the same day and same time of each week. I know these all, I'm not going to read all those, but we have a lot of these available. We get them printed. But I think they're really, really beneficial for the individual, not only in the recovery setting, reentry setting, but at home. Like you can utilize these accommodations every single day at home and with a short little look at this card. But I think it's really important to notice all those different types of symptoms that they're able to adjust and accommodate. Even when they return to work, those are something very, very small, you know, that they could really help them. That's kind of the overview, obviously, of the reentry side and a substance use correctional facility side of brain injury, but I do want to go over our brain injury program. So we are the lead agency for services for West Virginians with a traumatic brain injury. A lot of different states have brain injury associations, brain injury alliances, and we are essentially that for the state of West Virginia. The eligibility to get into the program, you have to live in West Virginia, you have to be a current resident of the state, and you have to provide medical documentations of a TBI, which is sometimes very difficult to do, especially in the reentry correctional facilities and substance use facilities, just because they sometimes didn't go to the doctor, right? But if we have that screening tool, they can take it with them, and then they could essentially, if you have a PCP, they'd be able to help get that diagnosis in order to get in the program. Long story short, this is our roadmap for the recovery. Once they sign release of information, we get documentation, then we'll set them up with a social worker, which I'll go over in a bit. We'll get them an ID card. Any person will send those as soon as we get documentation that you're a person with a brain injury. Best ways to be communicated with at the top, and then you can actually customize which symptoms that individual has. For example, if they have the top 2 symptoms, right? Poor coordination, balance, slurred speech, and impaired judgment. If you get pulled over, probably think that you could be intoxicated. If not, you can whip that out and hopefully get, you know, them to understand that. Obviously, if you're intoxicated, it's not going to do anything, not doing any good, but it is something that has come in handy with people at the grocery stores or, just to their neighbor or whatever it might be. That's kind of how our resource coordinators are broken up. We have 5 that are statewide. To find resources in a region is very important. So someone in Berkeley County or Grant County is not going to have any clue what the resources are in Wayne or Mingo County, right? So that's kind of why we like some region specificity whenever we through our clients. We'll do a needs assessment with that individual from our social worker. They'll create a plan and hopefully address any immediate needs and improve that quality of life aspect and promote some independence. And those could be really those linkages. They would just essentially make linkages after conclusion of that needs assessment. I think they're really important, especially if they need, let's say they need cognitive behavioral therapy or something, like that will come to fruition during that needs assessment. Or if they need speech therapy, that could be something they make a linkage to. If they've never been to a neurologist, we can make that linkage as well. It could be a lot of different things that they could utilize. Another linkage they can make, we pay for neuropsychological evaluations. Part of the grant is paid for through the Bureau for Behavioral Health, kind of like our whole program. But it's there to evaluate strengths and weaknesses and to create a plan. And a lot of times those neuropsych evaluations will come up with a list of recommendations for the client and for the patient, which are very, very, beneficial. My son, we just had one not long ago for my son with some sensory stuff, and just the list of recommendations was just eye-opening, right? Something so minute and small could potentially help them in the long run. The really big part of a program, we do have some financial assistance. It's called Funds for You. Again, we don't house the money. It's paid for. It's funded through the Bureau for Behavioral Health, through the DHHR. To pay you of last resort, you have to show denials that no one else will be able to pay for that. It could go to a variety of different things: dental services, medical vision services, past medical bills, home modifications. You could pay for a ramp, if it's they're wheelchair bound, they could pay for a ramp in order to get into their house, different therapies. We get a lot of car tires, which is like a big expense. So you could pay for tires for a vehicle. One of our most recent ones that's probably going to hit home a little to this call is one of the clients we have at Recovery Point. We just was able to use that funding to put a down payment on an apartment in the first month's rent, right? So that's a big deal for these people. So that's the beauty of having those smaller or those longer term facilities, is that they're able to have time to really develop a relationship with the social worker and hopefully get some of that kind of taken care of. I'm not going to worry about this one too much. This is more for teachers. It's a concussion management tool to help students get back to the classroom. Obviously, we do technical assistance trainings, certification, not certification, but we, do a lot of CEU trainings and different things. And we have this giant inflatable brain. It's that you can kind of see the signs on the outside and inside. They're interchangeable depending on the age demographic. Excuse me. You can go walk inside of it, walk around it. Shows the different lobes. You can see the big aneurysm on the right-hand side. But that's a really cool interactive tool. We take it a lot of places. Support groups. We got a lot of support groups. Caregiver support is a big one for us. And I'll put the website in the chat as soon as I'm done. So, and that's my information. It's also in the chat. And that's all I have.
You email maybe a copy of the slides?
Yeah, sure.
And also I was wondering, so you might have said it in the beginning, but I had a phone call, but how does someone qualify to take part in that program? So how do you guys have to do an assessment that says they have a brain injury, or how does that work?
No, they would sign an ROI, ROE, release information, external agency. So our intake coordinator can help find those medical records. So they have to find medical documentation of the brain injury. So even a word like history of traumatic brain injury, history of concussion, that would classify as to get involved into the program.
So if anyone has a history of a concussion or brain injury in their
And
medical
they have to
record
live in West Virginia.
and live in West Virginia, then they can take advantage of those services.
Correct.
That's great information. Thank you.
Yeah, you're welcome.
Yes, thank you, Jeremy. That was awesome. Very informative. The one slide you skipped a little too fast for me. Who is our resource coordinator in this whole Eastern Panhandle? I didn't catch
It'll be split. Her name's Charlene Liberto, more than likely. Yeah, Charlene Liberto. She lives in like Martinsburg area, Berkeley County.
So then in order to get someone involved in the program, you would just contact her?
Nope, I would use that website I just put in the chat. If you do that, there's an orange button. If you scroll down below, like the list of services, it says get services from the CED. Click on that, and then it'll be, I know, sorry, my dog's going crazy. And then they'll be able to fill out, like anyone can make the referral. You can make it for somebody. The person can make it for themselves, and then just kind of fill all that information out. And then our intake coordinator will be getting a hold of you and or the client, whoever is the appropriate person to do that.
What kind of dog do you have?
It's a Jack Russell. It's an absolute energy ball. I just took her out right before I came in, did this because I knew, but she didn't go to the bathroom, so I'm sure that's probably what it is.
How many people participate in this program?
We have we were on pace to almost hit 300 people this year. So it's a statewide program. So I think it has steadily increased, especially when we're getting into this population. I think it's such an underutilized program in this population. So I think whenever since we've done that recovery point, we're screening at Jacob's Ladder up in Aurora in Preston County. There's a place in Clarksburg. I want to meet someone in Wheeling next week. So we're starting to screen and kind of collect some of those numbers. So I think the more we do that and the more we do these type of trainings, I think we're going to be obviously getting some more, which is great. And those are, individuals that have had brain injuries for probably a really long time. I've never gotten any type of service in the past.
That's wonderful that this is available. When did this program start? Did you say 23?
Oh, no, this has been the screenings. We've been screening in that facility since 2023, but our program has been around for, I don't know how long. I've only been in part of the program for a little over 2 years. So it's been going on for at least 10 or like 15 or 20 plus years at the Center for Excellence in Disabilities.
Okay. Do you work directly with inmates who are currently incarcerated in jails or prisons?
Not yet, but not yet.
focusing-
That's kind of, we would love to, but it's so hard. I'm sure y'all know, I'm sure it's very difficult to get quote unquote in order to do that. And that's kind of why I want to get in a lot of these calls, just to kind of try to get in as many places as we can. So if we get into some of the reentry side of things, it'd be great to get involved when they're in there, because some of those accommodations can essentially be done there, right? And I think that's going to be and if you can kind of get in that process and get into that mindset of, and a lot of times it's like coming to the realization I do have a brain ailment. Some people have no idea of the cause of a why, and I think when they have the why, I think it makes sense from a mental health standpoint. It makes sense moving forward, and it'd be great to do that. But we've talked to a few. I have a contact at the Morgantown one, which is kind of a lower, the one here, it's down the road from my office. I have a contact there. They have a new warden, and he said that she's very involved with trying to get involved with some different organizations. So I'm going to try to get in there. It's going to be my first attempt to try to get in, but we'll kind of see. If you have recommendations, obviously I will take all of them.
I would try to contact someone at the DCR Charleston.
Yeah, I tried. There was a grant I was applying for a month, probably almost 2 months ago. And it was a $500,000 grant in order we want to do cognitive behavioral therapy for those that screen positive for a brain injury. And we were going to utilize the day report centers, since that is a consistent location for them to go to. and the DCR would not sign off on that grant. We needed a signature from them in order to apply for the grant. And they said since they weren't quote unquote directly involved, because we were not utilizing them, they would not sign off on that. So we ended up not being able to apply for the grant because of that reason. So I talked to a couple of day report centers, Jefferson in particular, and they are all in. They were all in. We had a location, and it just kind of didn't not come to fruition after that. So pretty disappointed. They gave me a couple contacts. I contacted the person, left a couple messages, and I never heard anything back. But the idea of it was you could partner it up and you could essentially we want to do a research project on it to, I think we were going to measure infraction rates for those with, that received the cognitive behavioral therapy and ones that did not receive it, if that made sense. And to see if there was a really interesting, correlation between that, and it never went anywhere. And that's what we were going to utilize the funding for, was to pay someone to do those cognitive behavioral therapy once or twice a week for those individuals. So we were going to pay that and pay for the treatment for a couple years to see what would happen, but didn't.
That's a really great idea. I love that. I
Yeah, thank
hate
you.
that bureaucracy sucks, but that's a great idea.
Yeah, and we're still trying to figure out how to best do that. And again, I'll take any recommendations, but we thought day report centers just because just because they have consistent contact, and that would be the only one I would be able to try to do that. But we want to do it across the board because that's a big thing in our needs assessment every year is people need cognitive behavioral therapy, but they're not receiving it. So and it's hard to pay for just general insurances. So we wanted to write a grant to hopefully pay for some of that, but didn't happen.
And then, Jeremy and then Heather from the Reach have been working together. So hopefully, some of our people that are going through as mentees can hopefully benefit from this program. And
That's
then Jeremy's, I don't know, colleague counterpart, Portland, will be speaking and presenting at the West Virginia Restorative Justice Conference next weekend. So there'll be more information about this too. If you're attending that conference, you can attend Portland's session.
Yeah, he's actually co-presenting with an attorney, a lawyer from the Mon County Public Defender's Office. So they're going to do it's going to be an interactive presentation. So they're going to have different scenarios, very similar to some of those reentry simulations, but just kind of put the brain injury in perspective with those decisions and with all those processes they have to do as well. So it's going to be really neat. There are 2 or 3 scenarios I think they have set up. We've been talking with them every week, kind of preparing that. So it'll be really interesting to see.
Hey, Anna, do you think SciMed would consider something like this? Do you think it'd be worth pushing Jeremy in that direction, give him a contact there?
I mean, maybe I don't know about the jails, because as a therapist, I can't even provide therapy there. Like that's not in their contract obligation. So, I mean, I could definitely, put a bug in Ashley's ear, the director of jail services, but I don't hold out a whole lot of hope.
Okay, well, I do appreciate that. Be patient, Jeremy. Things take time with the DCR.
I understand. Yeah, I'm beginning to understand that now.
Yeah. Wait 5 years, maybe you'll get that signature.
Okay.
But no, thank you again for presenting.
Yeah, and if anyone has any would like to start screening like that, sorry. If anyone has any would like to start screening and kind of collecting some of that numbers, I think that would be a really cool partnership, and interested in any type of research, we'd be obviously happy to kind of tackle that with you.
I know for certain I have 2 clients who have like a history of brain injury. So I would definitely be interested in getting more information. But did you put your contact information in the
Yep.
chat?
Yep, it's up there. Do you see it, or I can put it back in?
Wait, yeah, I don't see it. Well, because if you could put it back, that'd be great. Thank you.
I also have clients that have TBI. Is there any kind of pre-screening we should do to see if they are a good fit, or would you recommend anyone that's had a TBI to pursue this?
How we do it with Recovery Point, I do a training with their new like intake specialist almost every couple of months, and to inform them of the services that we provide, so then they can relay it. We obviously they have a lot of information, but they can relay that to those clients, and it's up to the client if they want the services or not, if that makes sense. So it's not forced on. We don't have 360 some clients from Recovery Point. We get one or two every other week. You know what I mean? Every week we get maybe one new one or so, but still it's a lot. But it's really, if you guys think of, especially you see them a lot and talk to them a lot, if you feel like they need some different type of resources, then I would recommend them.
Okay,
Mhm.
appreciate it.
And those neuropsych evaluations are so beneficial. They take a lot of work and a lot of time to coordinate and set up, and they're expensive, but just the amount of stuff that comes from them are just crazy, like just little tidbits about yourself that you probably wouldn't even think about just by answering some questions. It's like an all-day evaluation, but there's a ton of information that comes from those that we recommend. We've gotten a lot set up through, we work with the RNI, the Rockefeller Neuroscience Institute a lot at WVU. So we do refer a lot of people there and do those, but yeah.
Is that in Morgantown?
Yeah. And there's an RNI like over in the Eastern Panhandle in Berkeley County as well, that they're trying to figure out some information, kind of get things coordinated very similarly to the one in Morgantown. But
The neuropsych evaluations are included in those like benefits of being involved in the program.
yeah,
So I know they're like, you can't get insurance to pay for that most of the time in there.
no, they won't pay for them too much, but we have an agreement with a handful of neuropsychs through the state. We pay $2,000, and that's just kind of the going rate that we pay for them. I think they go a little higher, but just for the partnership's sake, they were able to kind of negotiate that for us.
I love that. That is great. I love it.
I think you talked about kind of like last dollar in. So what other resources are available to help cover the cost of those neuropsych evals?
That's like we have like how the grant works. We have so much money devoted to those neuropsych evaluations. So that neuropsych money does not come out of that funds for you money, like $2,300 a year. So that's completely separate. So that $2,300, like I mentioned, that individual that had that got the apartment, for example, from Recovery Point, like that money is separate from the neuropsych funding stream. So that but the social worker during that needs assessment will be able to determine essentially what exactly they need and where they need to go. And they're very creative if they want some funds for you funding, like they're very creative of finding ways to utilize it. Because if we don't use it, it's going to go away and no one's going to get it, it's going to reduce. So we try to use it. It is a bit of a process, I will say, on their end, because it does take some time to get it. Which sometimes is frustrating for the client, especially obviously if they have some mood disorders, so they get a little frustrated, but at the same time, it's something they haven't had in the past, so before and access to. So we provide that access for them in that regard.
But it sounds like DHHR will cover whatever is not covered by everybody else. So the clients shouldn't expect to have to pay anything out of pocket.
No.
Okay.
So I know you said that you have so you have an agreement with Recovery Point, but can we bring clients on an individual basis, or do we have, does the guild have to have an agreement also?
No, anyone can make a referral. You're good.
Okay.
Yeah. I'm just saying, if you screen, we would just want to see the numbers, because from a statistic standpoint, it's very interesting to be able to get buy-in from other partners as well if we have like a sure number of things, and we can break it down to male to female, or even location. That'd be really interesting. Yeah, that's the only reason we ask, and we have to report some of those numbers out to our federal partners because we are federally funded as well. So we always want to kind of report out. That's the only reason I mentioned that.
Well, we thank you again. Does anyone else have any other questions for Mr. Dixon? Nope,
Yeah, thank you again for having me.
absolutely.
Mhm.
Look forward to working with you in the future. Absolutely. Krisha, do we have anything going next month yet scheduled?
No, sir, we do not have a speaker or presenter, so.
What about Raj?
Raj,
The
our
Crave
Raj?
Alert.
Yeah, we've had him on before, but it's
Oh,
been a
it's
while,
been
and
a while.
we've kind of implemented that new Crave Alert. It's a good idea, Becca.
Hey, Katie's with him now, so we should probably call her when we get done this meeting and maybe she can ask him.
Okay. Sounds good. And I will let you know, Chris, if we can get him to come present it again for us.
Yeah, he hopped on one of the other council meetings the other day. It was the first time I'd seen him in a while, so.
Oh, did he?
Yeah.
Okay. Yeah, he makes his rounds.
Yeah.
All right. Well, our next reentry meeting is first Thursday of the month, so I don't even know what that is.
The 6th.
That would be July 4th, wouldn't it?
Wait, am I? The 6th. It's
It's
the
the
6th.
4th.
No, just kidding, just kidding. I'm looking at the wrong month.
Yeah, July 4th. So we will all be here, I'm sure. Unless your agency takes the 4th of July off.
It is up to you, Eric. What do you want to do? I mean,
I mean, the
we
guild,
can
the guild
move it
is
to another
off.
day. We can skip that month, whatever you want to do.
We are off that day, Eric.
Well, I have my boss and my boss's boss. What do you all want to do? If we're closed, do you just want to,
Yeah.
I don't know,
I mean, you
skip
can,
it, maybe just shoot for August?
That works for me. Anna, that work for you?
Yeah, that would be fine. I mean, if we could do the next week,
The 11th.
I would be fine with that too, the following Thursday. But if everybody wants to skip it, especially if you're struggling with a presenter, it's up to you, Eric.
Well, let me check with Krisha real quick. How does that affect your schedule? Do you have other council meetings that,
that's what I was just looking at, that there is nothing on July 11th at 10, so.
okay,
Yep.
can we go with July 11th?
Yep. So I will make that correction to the flyer and, I haven't sent out or scheduled the emails to go out yet for July, so I will make that note on there.
Okay, wonderful. And I will get back to you if Raj is willing to present,
Perfect.
if he's available. Okay, does anybody else have anything?
Thank everyone for what you do and who you are. We couldn't do this without everyone.
Yes, thank you, everybody. And thank you again, Jeremy. That was awesome. Very informative.
Good job, guys. Thanks.
Okay, well, hope to see everyone on the 11th.
Thank you.
Bye-bye.